Ever had that moment where, I don't know, a seemingly minor punch goes a bit wrong? Maybe hit something harder than expected?
hmm Or seen a sports injury, perhaps, like a thumb getting a sudden, really awkward jolt.
Exactly. Those kinds of things, well, they can often lead to what we're going to unpack today, a Bennett's fracture.
Yeah, absolutely. We've got some focus revision notes here, and the plan is basically to pull out all the essential info you need on Bennett's fracture. Make it clear, make it memorable for revision.
That's the mission. We want you to walk away understanding what it is, how it happens, how to spot it, manage it, the whole picture.
We'll cover the definition, causes, who's at risk, mechanics, what else it might look like.
Right. Differentials, how common it is, presentation, diagnosis, treatment, prognosis.
And importantly, yeah, the potential complications too.
Okay, ready to get into it.
Mhm.
Let's start with the definition. What exactly is a Bennett's fracture?
So in simple terms, it's a fracture right at the base of the thumb's metacarpal bone, that long bone in your thumb.
Okay, the base of the thumb, metacarpal.
Yeah, and specifically, it's an intra-articular fracture. That means the break actually extends into the joint surface.
Into the joint itself, the carpometacarpal joint.
Precisely.
Yeah.
Where the thumb metacarpal meets the trapezium bone in the wrist. And crucially, this fracture almost always involves some displacement, some dislocation of that joint, usually towards the wrist.
Ah, so it's not just a crack, it actually disrupts the joint's alignment.
Exactly. The fracture line itself tends to be oblique, kind of angled, running towards the palm side.
Okay.
Now, they're not all identical. Some might be relatively stable, others quite unstable. And the classic mechanism, like you mentioned earlier,
Right.
it's often an axial blow on a partially flexed thumb metacarpal.
Like that punching scenario.
Just like that force down the length of the bent thumb.
Mm-hmm.
What's really interesting is how it displaces.
Mm-hmm.
There's usually a small fragment on the volar or palm side that stays put. It's held there by a strong ligament, the volar oblique ligament.
Okay, so one bit stays anchored.
Right. But then the main larger part of the metacarpal gets pulled away. It's pulled proximally and radially by the abductor pollicis longus muscle, that strong thumb muscle.
Ah, so the muscle pull actively causes the displacement. That makes sense why it would be unstable.
It's a key part of the pathophysiology, yeah.
And being at the base of the thumb, I mean, the thumb's so crucial for grip dexterity. This must have real consequences for hand function.
Oh, absolutely. It can be quite debilitating if not managed properly.
Okay, definition clear. Let's talk etiology then. How do these typically happen? What causes them?
Well, the fundamental cause
Mm.
is that axial force directed along the thumb. The notes highlight a couple of common ways this happens.
Mm-hmm.
One is a direct blow straight onto the thumb, maybe in sport, or a fall directly onto it.
Okay.
The other classic one is falling onto an outstretched hand, but specifically when the thumb is slightly bent or flexed under the hand at impact.
Ah, so the force travels up the hand.
Exactly, and it creates this sort of shearing or compressive injury right at the base of the thumb metacarpal.
Got it. Direct blow or force transmission through a fall with a flexed thumb. So, are some people more likely to get this? Any specific risk factors we should know?
Yeah, the notes list a few. Things like repetitive thumb movements, especially forceful ones. Maybe certain jobs or even playing certain musical instruments could potentially increase stress there over time.
Okay, repetitive use.
Also, high impact or contact sports. That's pretty obvious, more chance of direct trauma.
Makes sense.
And finally, if someone's had previous hand or wrist injuries, maybe the structures are a bit weaker or the biomechanics are slightly off, potentially making them more susceptible.
Right. So, repetitive stress, high-impact activities, and previous injury history. Good to keep in mind. Let's dig a bit deeper into the mechanics, the pathophysiology. We touched on the muscle pull.
Yeah, so the core problem is that break at the base of the thumb metacarpal. The fracture pattern itself, as we said, is usually oblique. Sometimes it can be comminuted, broken into more than two pieces, but the classic Bennett's is that two-part oblique fracture.
Okay.
And the key consequence, really driven by that volar ligament holding the small fragment and the abductor pollicis longus pulling the main shaft.
The tug of war you mentioned?
Exactly. That tug of war leads to displacement and therefore instability of that carpometacarpal joint. The joint surfaces just aren't lining up properly anymore.
That visual really helps understand the instability. Okay, so someone comes in, pain, swelling at the thumb base after an injury. What else could be going on? What are the main differential diagnoses?
Good question. It's really important not to just assume Bennett's. You need to consider other things. A key one is a Rolando fracture.
Rolando, how's that different?
It also involves the base of the first metacarpal, but it's typically more complex. Think a Y-shaped or T-shaped fracture pattern, often more comminuted, more fragments.
Okay, so more complex break pattern.
Yeah. Then you could have a pure dislocation of the trapeziometacarpal joint, the joint pops out, but without that specific Bennett's fracture pattern.
Just a dislocation, no fracture, or minimal fracture.
Right. And finally, don't forget simple sprains or other ligament injuries around the thumb base. They can cause pain and instability too, so you need to rule those out.
Makes sense. Symptoms might overlap, but the actual injury and management could be quite different. What about how often we see these? Epidemiology. Are Bennett's fractures common?
Compared to all the hand and wrist fractures out there, no, they're considered relatively uncommon. You won't see them every day.
Okay, important to know, but not super frequent. So let's paint that clinical picture. How does the patient usually present? What are the key features?
Well, the absolute classic signs are pain, swelling, and tenderness, really localized right to the base of the thumb.
Yeah.
At the CMC joint.
Right at that joint line.
Exactly. You might also see some obvious deformity compared to the other side. Patients will usually say it's really painful to move their thumb, especially trying to grip or pinch anything. Using the thumb becomes very difficult. Bruising around the base of the thumb is also pretty common. And when you examine them, you can often feel or demonstrate some instability, some abnormal movement at that joint.
So a painful, swollen, maybe deformed thumb base, difficulty using it, potentially unstable on exam, especially after a relevant injury. That should definitely ring alarm bells for Bennett's.
Okay.
How do we confirm it? What investigations are needed?
The main diagnostic tool, really the cornerstone, is getting plain x-rays. You need good views in the hand, but specifically focusing on the thumb.
What views are essential?
You absolutely need at least 3. An AP, anteroposterior, an oblique, and a true lateral view of the thumb itself.
Okay, AP, oblique, lateral.
Yeah.
And what are we looking for on those x-rays? What confirms a Bennett's?
You're looking for those classic findings we talked about, that oblique fracture line running across the base of the first metacarpal. You'll often see that small triangular fragment of bone, usually on the ulnar side of the base, the side towards the pinky. And importantly, that fragment often stays attached to the trapezium in its normal spot.
Right, the bit held by the ligament.
Exactly. And the other key finding is that the main shaft of the metacarpal is displaced proximally. It's shifted up towards the wrist, pulled away from that little stable fragment.
Oblique fracture, triangular fragment, proximal displacement, maybe. OTP for Bennett's, could that work?
OTP, oblique, triangle, proximal. Yeah, I like that. That could definitely help you remember the key x-ray features.
Cool. So the x-rays are key for diagnosis. Why are those multiple views so important, though? Can't you see it on just one?
Well, sometimes you might. But the different views let you really assess the fracture line's orientation, judge the amount of displacement in different directions, and spot any other subtle injuries. Sometimes things are hidden on one view, but obvious on another.
Okay, gives you the full picture. Is CT ever needed?
Occasionally, yeah. If the fracture looks really complex on the x-ray, maybe very comminuted, or if there's a strong suspicion of other injuries like ligament damage that aren't clear on the plain films, then a CT scan can give much more detail, that sort of 3D view. Got it. X-ray first, CT, if needed for complexity. So now we've diagnosed it. How do we manage a Bennett's fracture, say, here in the UK?
Right, management really hinges on how stable the fracture is and how much it's displaced.
Okay.
If it's a stable fracture pattern and there's very minimal displacement, the joint surfaces are still pretty well aligned, then conservative management might be an option.
And what does that involve?
Usually immobilization in a thumb spica cast. This holds the thumb and wrist still to keep the fracture reduced in the right place. Plus, of course, pain management and regular follow-up, including repeat x-rays, to make sure it's healing correctly and hasn't shifted.
Okay, casting for the stable ones. When does it need surgery?
Surgery, typically open reduction and internal fixation, or ORIFF, is generally the way to go when there's significant displacement. If you leave those fragments displaced, there's a high risk it'll heal wrong, what we call malunion.
And that leads to problems down the line. Yeah, often chronic pain, stiffness, weakness, and arthritis. So the surgery aims to put the pieces back together anatomically, perfectly aligned, and then hold them there while they heal.
How do they hold them?
Usually with small implants like screws or sometimes K-wires. After the surgery, the thumb still needs to be immobilized for a while, usually in a splint or a cast.
Right, so surgery realigns and fixes it internally. What about rehab afterwards, for both conservative and surgical routes?
Yeah, rehab's crucial. There's always a period of immobilization first, typically in that thumb spica cast, maybe for around 2 to 6 weeks, depending on the specifics. After the cast comes off, patients usually move into a removable splint, often made of thermoplastic. This still offers protection, but allows for gentle, gradual mobilization exercises to start.
Getting the movement back slowly.
Exactly. And hand therapy, physiotherapy is really key here to help regain the full range of motion, strength, grip, and overall function.
Makes sense. A period of rest, then gradual guided movement. So what's the overall outlook? If someone has a Bennett's fracture, what's the prognosis generally like?
Generally, it's pretty good, especially if it's diagnosed early and managed appropriately. Most people heal well and can get back to their normal activities.
That's encouraging.
But, the outcome does depend on a few things. How severe the initial fracture was, how much displacement there was, the patient's age, how well they stick to the treatment and rehab plan.
So compliance is important.
Definitely. Good rehab adherence makes a big difference.
Are there potential long-term problems or complications we need to warn patients about, even if things go well initially?
Yes, unfortunately, there are a few potential issues.
Yeah.
One big one is post-traumatic osteoarthritis in that thumb CMC joint. Any injury that damages the joint surface increases the risk of arthritis later on.
Okay, arthritis is a risk. What else?
Some stiffness or reduced range of motion in the thumb can persist, especially if the immobilization period was very long. There's also a small risk of the joint remaining unstable with recurrent subluxation, meaning it partially dislocates. And with surgery, you always have the general risks like infection, either just the skin or, rarely, deeper in the bone, osteomyelitis. And specific to this area, there's a small nerve, the dorsal sensory branch or the radial nerve, that runs nearby and can potentially be bruised or injured during the initial trauma or the surgery, leading to some numbness on the back of the thumb.
Okay, quite a list. Arthritis, reduced movement, recurrent instability, infection, nerve injury. Is there a way to remember those?
Actually, yeah. You could use the mnemonic ORR.
Okay,
RPD.
O for osteoarthritis.
R for reduced movement.
Another R for recurrent subluxation.
P for postoperative infection.
And D for dorsal nerve injury. ORRPD. That's really useful, thanks.
No problem. Mnemonics can definitely help lock things in.
Okay, let's try a quick practice question then, really nail this down for everyone listening. Picture this. A 25-year-old comes in, pain at the base of their thumb happened when they punched a wall. Okay. Which of these is the most likely mechanism described for a Bennett's fracture? Is it A, a twisting injury to the wrist, B, a direct blow just to the tip of the thumb, C, an axial blow on a partially flexed first metacarpal, or D, a fall onto an outstretched hand with the fingers straight out?
Based on what we've said and that punching scenario, it's got to be C, an axial blow and a partially flexed first metacarpal.
Exactly. That's the classic mechanism. Perfect. One more.
Sure.
Which X-ray view is generally considered most crucial for that initial look at a suspected Bennett's fracture? A, lateral view of the wrist, B, anteroposterior view of the hand, C, oblique view of the elbow, or D, skyline view of the patella?
Okay, well, C and D are way off.
Yeah.
Between A and B, while you need multiple views, including thumb views, a good initial AP of the hand often gives you that first clear look at the base of the first metacarpal and any displacement. So I'd go with B, anteroposterior view of the hand.
Fantastic. You're right. While specific thumb views are essential, the standard hand AP is often where you first spot it. Great. So let's quickly summarize our deep dive on Bennett's fracture.
Okay.
It's that intra-articular fracture, base of the thumb metacarpal, always with some dislocation or subluxation, usually caused by that axial force, like a punch. Remember the abductor pollicis longus pull making it worse?
Diagnosis relies on X-rays, AP, lateral, oblique. And remember our OTP mnemonic for the findings. Oblique fracture, triangular fragment, proximal displacement.
Right. Management depends on stability and displacement. Could be casting, could be ORIF surgery. Prognosis generally good with proper treatment.
But watch out for complications. Use ORRPD, osteoarthritis,
Yeah.
reduced movement, recurrent subluxation, postoperative infection, dorsal nerve injury.
Excellent summary. And it really highlights how, what seems like a small fracture in the thumb can actually have pretty big implications for overall hand function. Understanding these specifics is vital.
Absolutely crucial for good clinical practice.
Totally agree. And listen, if you're revising for your MSRA and want more deep dives like this, practice questions, all sorts of resources, definitely check out pastmsra.com.
Yeah, it's a great resource.
Yeah.
And don't forget freemsra.com too. Loads of excellent free materials and questions there as well to help you prepare.
Both highly recommended.
Yeah.
So, final thought to leave you with. We've looked closely at how this specific fracture impacts function. Maybe think about this. What other seemingly small, localized musculoskeletal injuries can end up having surprisingly significant, long-lasting effects on a patient's life? Something to ponder. Until next time.